So taking a closer look, and actually this morning's talk, the one that was canceled, I believe would have spoken to this in greater detail, and I'm only going to hit the highlights, and I'm not even going to run through the numbers for you here. But the use of illegal opioids is a widespread problem, more so in Canada, only because we have more prescribed opiates and opioids. So since we have more prescribed painkillers, there are more painkillers available for illicit use. And the painkiller that has gotten most of the press, and deservedly so, is OxyContin. The term hillbilly heroin that's a term that's embraced in the United States of America. A real quick history on that is that the same regions that were notorious for the moonshine trade of alcohol during the days of Prohibition and gave rise to the whole hillbilly culture, in fact, is the area in the United States where most of the OxyContin is trafficked, and that's where it got that term. It really has no applications to us in Canada, except to say that OxyContin is doing a lot of the same damage that heroin does. So Canada ranks amongst the highest in consumption of medical prescribed opiates in the world, and in fact the talk this morning was to highlight that Canada was in fact #1. And again, I would have loved to have seen that talk, but I didn't. But one of the things that seems clear is that Ontario ranks one of the highest, if not the highest, in the world. Okay. My apologies, folks. There we go. I don't know whether your screen went blank for a second, but mine did. So interestingly, that opioids still will kill people, even though they're prescription. And one of the nice things about OxyContin, and by nice I mean what the patients appreciate, is they usually know what they're getting. With heroin, for example, the purity is never clear, and a patient might get a very impotent or low-strength dose of heroin, or they may get a highly potent and concentrated heroin, which is, of course, a problem for them because they're never really sure what they're getting. So patients who abuse opiates like to abuse medicines like OxyContin simply because, and you can see in that photo there, you see a nice green tablet with an 8-0 right on it. The patient knows exactly what dose they're getting. And this gives them a reassurance, and I think a misguided reassurance, that they're not going to overdose themselves. That said, 300 people per year in Ontario on average will die from overdose of opiates. HIV, by comparison, 1/3 of that number. And the final point on this slide is Canadians taking 5 times more prescribed opiates than residents of the UK, for example. Of course, what that means is that more and more of Canadian medicine cabinets have these medications. And that becomes a concern simply because most people, particularly young folks who are very prone to abuse, misuse, and eventually addiction of drugs, will get these from their family's medicine cabinets. And there's a good series of commercials on TV which alludes to that. So right now, not a surprise that alcohol and cannabis are the most widely prescribed, most widely abused and used class of drugs in high school students in Ontario. But number 3, and at quite a high rate, is the opiates, and as I said, surprisingly higher than tobacco use. So, interesting thing, why has OxyContin become sort of the #1 or the most widely prescribed and abused opiate? Part of it is what I alluded to earlier, that for people who are abusing the drugs, particularly people who will snort or inject the drug, they get a false sense of security in terms of knowing what the dose is that they are getting. But in order to fully understand OxyContin, it helps to take a step back. I was in family practice in the mid-1990s when OxyContin was released to the world, and I can recall being invited to sessions, educational sessions, dinner sessions, and so on, to describe this wonderful new drug. The wonderful new drug called OxyContin was a slow-release form of oxycodone, which apparently had no abuse potential and no potential for addiction. And I don't know if some of you are chuckling, but that was how it was marketed. And we as family doctors and specialists and so on embrace this. Maybe it was wishful thinking, but here's an opportunity to help people with pain, to really help real people with pain, and not worry that we're going to turn our patients into drug-dependent and drug-addicted individuals, and also not worry about the drug falling into the hands of the misusers only because it was said that it wouldn't lead to a high, it wouldn't lead to intoxication. The explanation was that it's a slow-release drug. Of course, what the folks who manufactured OxyContin could never predict is that people would learn that simply by peeling away the waxy coating of the pill and grinding the pill into a fine powder, it could be snorted or injected and have essentially the same pharmacokinetics, meaning the same rate of absorption, the same rate of hit, shall we say, as traditionally abused drugs like heroin. The other thing about OxyContin, on a milligram per milligram basis, it's about double the potency of morphine. And Ontario, the Ontario Drug Benefit Formulary, also embraced this new drug and made it available for full coverage in 2000. So these are some of the features, a perfect storm, if you'll call it, that has allowed OxyContin to become the #1 abused opiate or opioid in our province. There are solutions. Solution #1 is education. The session today is part of that education. The trouble is, though, the ones who should be educated are the ones who are most responsible, unfortunately, for the misprescription of these medications are generally the docs who will not be attending sessions such as this. So we hope that everybody attending will sort of spread the word, spread the gospel, so to speak. The safe prescribing of opioids. There's nothing wrong with opioids. When used properly, they are wonderful drugs. For people who have serious pain conditions, they could be life-saving drugs. There's nothing wrong with the medications, but they need to be prescribed a lot more appropriately. And if we in Ontario are the #1 prescribers of this class of drugs in the world, there's probably something that we're doing wrong. There are narcotic safety awareness implementation programs. The drugstores are now able to alert physicians to patients who are obtaining illicit or not illicit, but controlled drugs through multiple sources. So those are initiatives that will hopefully decrease the over-prescription of these drugs and as a result decrease the abuse of these drugs. And then finally, and I guess the reason why I'm speaking today, is the opiate agonist treatment programs. So that is, unfortunately, a little bit of slamming the barn door after the horses have left, but it is a treatment program that will allow many people to regain their lives and their sobriety after having fallen into the addiction of opiates. So very quickly, and I'll give a quick rundown on this because I want to get to the myths and your questions, obviously. So opiate agonist treatment programs. At this point, we have 2 medications that we'll use that will substitute for opiates. These are methadone and Suboxone. Both methadone and Suboxone are long-acting opiates. Both methadone and Suboxone will replace for the opiate-addicted individual the opiate that their brain requires in order to function at this point. A person who is opiate-dependent can stop cold turkey, but it's an incredibly painful process. As I said, pain, insomnia, nausea, vomiting, diarrhea, you name it. A patient is rarely successful in quitting cold turkey. So where the methadone and Suboxone come in is these are drugs that will allow the person to avoid withdrawal while at the same time getting away from their illicit drug use. And that's basically the opiate agonist treatment programs in a nutshell. There are some differences between Suboxone and methadone. Methadone is a pure mu opiate agonist, which, as you'll see here on the second point, should prevent withdrawal without inducing euphoria, sedation, or analgesia. That said, it will not induce euphoria, sedation, or analgesia in a person who is A, opiate dependent, and B, a person who's taking the medication at the proper dose. If an opiate-naive individual was to take methadone, they would see all the same effects as other opiates, up to and including intoxication, respiratory depression, and death. A person who is opiate exposed and opiate dependent can also overdose from methadone if the dose is much higher than it need be, or if methadone is mixed with other drugs that can increase the risk for overdose, such as benzodiazepines, so Valium family drugs, or alcohol. Methadone has been around and used in programs such as ours for treatment of opiate addiction dependence for the better part of, it's almost 50 years now that these medications have been around. So the medications have been studied, the progress have been studied, and bottom line is there's the illicit drug use decreases provided a patient is successful in their program. Decreased transmission of HIV and other bloodborne infections through the decrease and eventually, hopefully, the abolition of intravenous drug use. And obviously, when one buys methadone for $7 a day instead of buying OxyContin for $107 a day, one can imagine that the decrease in illegal activity and the cost of society will go down. Last but not least, when the person gains control over their addictions, the risk to their health and perhaps their mortality is decreased. So methadone is a pure mu opiate agonist, which means that it stimulates the receptors in the brain maximally, the same receptors that are stimulated with use of OxyContin, heroin, morphine, and so on. Where Suboxone differs is that is a partial agonist, meaning it excites the brain receptors only to a small degree, not a small, but only to a partial degree. It is less likely, therefore, to impart sedation or intoxication or overdose. But what is nice, or what is effective about the Suboxone, is that the receptors in the brain are essentially interfered with. The receptors in the brain that respond to opiates are blocked to some degree, such that other opiates will have less of an impact on those receptors. Now, there is a misperception out there with regards to Suboxone. I have patients who come to me all the time and say, listen, I'd like to start the Suboxone. I hear it'll make you sick if you use other opiates. Patients are thinking of a process similar to that with Antabuse. Antabuse is a drug actually no longer available in Canada, but it's a drug that blocked alcohol use, in that if a person took Antabuse as prescribed and then had a drink, they would feel very ill and hopefully come to the conclusion that they're not going to do that again. The perception of Suboxone for many people is that the Suboxone works in that same function, that if you take an opiate, you'll feel sick and you won't do it again. And that, in fact, is not true. But Suboxone will block the effect of other opiates to a great degree, with the hopes that the person will realize that there's no sense wasting the time, money, and energy on obtaining opiates because they just will not get the job done. Suboxone has certain advantages over methadone, and there are certain disadvantages, and you have to choose the one that makes the most sense for the patient. One of the most significant advantages of Suboxone over methadone is that the stigma is so much less, because everybody's heard of methadone, but not that many folks have heard of Suboxone. Both the Suboxone and methadone are prescribed in Canada based on very strict guidelines. The College of Physicians and Surgeons monitors patients in methadone programs, and the guidelines are largely centered around community and patient safety. Patient convenience doesn't enter into it at first, in that when patients start the methadone program, and again I'm using methadone program as a term to speak to either Suboxone or methadone, but when a patient begins an opiate agonist treatment program, they are required to take their medications in clinic every day, 7 days of the year, 31 days in a month. They are required to provide urine samples which prove that they are staying free of drugs of abuse. They are required to see their physician. They are required in our clinics to speak with our addictions counselors. So the methadone guidelines, or the opiate agonist therapy guidelines, are very specific and very rigorous. It's not by any means a walk through the park for our patients. Methadone must be taken, actually, nope, I didn't mean to go back, there we go. Methadone must be taken orally observed, so it's a liquid that's taken in clinic, as I said, every day initially. Over time, the patients are in carry doses. Carries are medicines they get to take home with them, such that a patient who's doing very well might get a Sunday dose that they'll pick up on Saturday, and Sunday they get to sleep in or hopefully go to church. This is one of the rewards that patients will earn with advancement through the stages of the program. The dose is individual. I've got patients right now who are on 2 milligrams of methadone, and I've got patients who are on 300 milligrams of methadone. The range is quite substantial. Most patients will dose between 60 and 150 milligrams. Suboxone is a tablet that dissolves under the tongue, and Suboxone actually is a combination of two medications. So buprenorphine, and buprenorphine is the long-acting opiate analogous to methadone. But buprenorphine is combined with naloxone, and naloxone is an antagonist drug. Naloxone is a drug that one will give to someone who has overdosed on opiates, for example, to reverse that overdose. Naloxone, when taken sublingually, is inert. Naloxone will not have an effect on the body. If, however, one were to grind up and inject a Suboxone tablet, the naloxone portion will throw that person to withdrawal. One, that will decrease their risk of overdosing. Two, that will make them sick enough that they're not going to consider making that mistake again. So Suboxone is actually two drugs, buprenorphine and naloxone. It's also given at the clinic originally on a daily basis. Patients will earn carry privileges, and as with the methadone and with many other medicines, of course, the dose is individually determined based on the patient's tolerance, their body weight, and so on. Most patients on buprenorphine, most people on Suboxone will be at the buprenorphine equivalent of 4 to 16 milligrams.